Time being 7 o'clock, I'm going to call this Board of Health meeting to order. All members are present, including our Director of Public Health, Marty Golightly. I'm going to ask that we please have a moment of silence for Terry Burgess, who passed away, I believe, 2 weeks ago. Thank you. All right, the first following item on our agenda is a message from the board. I have a statement I want to read here to discuss some of the things that have happened over the past couple weeks. As most of you know, and everybody here knows for sure, we've had to cancel the last two board meetings for different reasons. We plan to meet on August 16th to discuss a recommendation to the school committee for masking in schools. And this decision was to meet because of an August 9th email the board was forwarded by a school committee member asking what the Board of Health thought on the issue. In the interest of transparency and complying with open meeting law, I decided that a board meeting to discuss a recommendation was the best course of action. So following the school committee's letter to parents, it became clear that a recommendation from the board would have been a moot point, and the school committee had already taken a position. The Board of Health has broad authority to issue reasonable health regulations and public health orders pursuant to Chapter 111 of Mass General Laws. And furthermore, our mission is to protect, preserve, and promote the health and well-being of all Abington residents. So with this in mind, and the fact that infection by school-aged children, especially our unvaccinated 12 and under children, cannot be dissociated from decisions that impact the entirety of the town, I called another board meeting to discuss a townwide mandate on August 23rd. So let me be clear, this meeting had absolutely no correlation to the meeting of the school committee. It was intentionally offset by an hour to not meet at the same time as them. There were logistical issues of getting a quorum on any other day of the week, and I felt it was important to allow all departments, especially the school department, enough time to react should the board vote on such a mandate. So we strive to provide the best recommendations and policies and need to weigh all factors when doing so. The health department does a tremendous amount of research and publication review to stay on top of all the latest relevant data and studies so they can provide the best and most accurate technical advice to both residents and the board. Together, we have been monitoring the potential impacts that infections in our school-age population, especially unvaccinated 12 and under children, can have on family units, as well as the ability for them to transmit the virus, some of which I know Marty will speak to tonight. As not to step on the school committee's toes and to still consider our mission in charge of protecting, preserving, and promoting the health and well-being of all Abington residents, a townwide order was put on the agenda for discussion and consideration of the concerns previously mentioned. This type of an order allows each department to implement the order in a manner consistent with specific issues and circumstances within their department. Because the board makes every attempt to stay up to date with the latest guidance, we will, when appropriate, reschedule meetings if information will present itself shortly after a scheduled meeting. The Board of Health canceled the meeting scheduled for Monday, August 23rd, to be able to understand and fully synthesize the DESE Commissioner's statement on August 24th and revisit this conversation today. My job as the chair of the Board of Health is to ensure we are following all the rules and regulations we must abide by while still providing the most transparent coverage of our consideration of new data, regulations, and all business of this board. I know we all want the same thing, and that's to keep our residents safe and healthy. So please, let's be productive, let's work together, and strive to create the safest possible environment for all our residents to live. That's all I have to say, and I want to turn things over to Marty for our COVID update.
Sure. Okay. So in front of you, I had to print out the Excel spreadsheet. I'm sorry to do that to the paper. As I said earlier, there's some audio-visual problems in this room that forced me to do this. There's a chart on the third page of the first one that's the running tracker of our current active cases in town. And it goes all the way back to July 1st of 2020. And you can see on that chart, we are still kind of on the upward tick. And every now and then we get a little downward trend like today's 25 cases. And we don't look at any day individually. We look at the growth pattern over a certain amount, right? We look at a running average for 2 weeks. And we are still trending upward, but I can't help myself but try to be as cautiously optimistic as possible. Next we have our total cases, and there's a nice graph on that one that I apologize continues on the second page at the bottom of it, and you can actually see it back there you go, yep. And that is still on the upward tick. And I think if you kind of look back to around the end of August, that's last week of July, you can see where Delta became the predominant variant by outcompeting Alpha. in Massachusetts is when those cases numbers actually started to grow. And that's consistent with the data in the actual Excel spreadsheet. If you look back to about the 28th, you'll see that exponential growth till now. We gained about 100 cases in a month. And that was the most for a long time. Next is our test positivity graph and rate. We're about 3.31, and we've hovered in the threes almost for the entire month of August. After doubling a little bit more from the last week in July into the first week of August. And then it doubled again almost as August 11th and has stayed in the threes around 3.3. And that graph kind of illustrates a plateauing that a lot of surrounding communities are hopeful will happen in the test positivity rate. I'm not so sure about that. And the reports or the discussion or the anecdotes that they're doing fewer tests, which is why they're having more positives, just isn't true. If you look at the Google spreadsheet that I sent to all of you, you'll notice that we actually track how many tests are done for every week that they send it out, and it's been more the last couple weeks. And then after that, you'll find our vaccination percentages, and our percentage of eligible is still around 66. Sorry for the tiny font. Yes, it's kind of best for me too. Our percentage of eligible is about 66, and our percentage of total is about 57. And discussing that with the leadership of other surrounding municipalities, we are staying around the same as all of our neighbors. And we can talk about how we get that higher when we talk about the vaccine update. But that's really the numbers, and if you don't mind, I'll go into the COVID update to answer the question that Aaron asked me earlier, why we should not disassociate school-age children with the entirety of the town. And to do that, I can't just say this is why. I want to be able to show you guys what I'm looking at and exactly why I think it's important that we don't disassociate all residents of the town, especially the unvaccinated. The first thing that I gave you is it's a Lancet study that has to do with hospital admissions and emergency care when you compare the Delta variant with the Alpha variant. It's this one right here for everybody to follow along. Basically, and I encourage you to read it, it can be a little dense, so I'll summarize it if you don't mind, that the Delta patients were younger, the median age was around 29, whereas the Alpha variant, the median age was a little higher than that. Also, Delta patients were 2 times the risk of being admitted to the hospital than the Alpha variant, and that's a significant increase. I don't need to explain that. And the percentage, this is what I thought was interesting, the Delta patients were more likely to use emergency services. And this is tracking with all of our hospitalization uptick, all of our ICU uptick, that not only is the Delta variant more infectious, it's also more serious if you get it. And this doesn't specify whether it's unvaccinated or vaccinated some of the time, but it's primarily most patients were unvaccinated. And all of that, again, I encourage you to read it. And I'll have links to all of this if anybody wants it. Anybody watching or listening wants it. So I had to compare Delta with Alpha just to kind of, so everybody understands that Delta is both more infectious and can lead to more serious outcomes, especially in the unvaccinated. And the next study is one that I sent you guys before, so I apologize for a little bit of redoubling of efforts here, but it's the JAMA Pediatric study. That it basically, this is that index cases increased risk of transmission in households. And I'm including this, and this is kind of like one of the reasons why we worry about every case and not just, every case matters, basically, is what this kind of tells us, because an index case is that initial case and goes to a household and then spreads it to the rest of the family, and we know Delta can have a higher incidence of breakthrough cases, so we do need to track that thing. Children aged 4 to 8 and 9 to 13 had increased odds of transmission, and the highest odds of transmission were observed in children 0 to 3, and that makes most sense, especially anecdotally, if you think a 0 to 3 child needs significantly more contact than older children. So that tracked with like the eye test as well. And all of the data is in here to kind of support that conclusion. Basically, in this cohort with pediatric index cases, the adjusted odds of household transmission by children 0 to 3 was 1.43 compared with children age 14 to 17. What that means is we should be considerate of all of the cases in town and their effect that they could have on all households. If the household has an unvaccinated member, or even if there's a breakthrough case in someone with multiple comorbidities or underlying medical problems, that is significant, and we should be worried about that. So we can't just say, well, it's just cases, because every case could lead to a breakthrough infection, or it could lead to some other outcome that we don't want, which we'll talk about in a few minutes. Also, from this week, August 27th, the CDC put out in their Morbidity and Mortality Weekly Report a case study for the Delta variant outbreak in an elementary school in Marin County, California. And why am I bringing this up? One of the things that we have spoken of, I don't even know how many times ad nauseum, was people going to work with symptoms and how important it was to not do that. And then going to work with symptoms and a pending COVID test. Please don't do either of those things. Please stay home if you are sick. Please stay home if you have pending test results. And one of the teachers from Marin, the second page is really telling on this. It has the seating chart of that classroom. The teacher went to school symptomatic, and she was taking her mask down so she could read to the students. Now, this was in a well-ventilated classroom with an air filter. All the doors were left open and all the windows were open. And you can see by the seating chart that the entire first row tested positive. 4 of the 5 students were symptomatic in that first row. 12 of the 24 students in that classroom subsequently tested positive. And there were 2 other symptomatic cases. And the interesting part of this seating chart is there are 2 students in the back row who tested positive. So there was a lot of movement of the particles in that classroom. So this is just one of the reasons that why we can't look at just are mask effective. It is a combination of a lot of other things. Wearing a mask, having that ventilation, and getting our kids as far apart as we possibly can. So this is a very telling study in that someone went to, this is a very telling report, excuse me, that someone went to school, took their mask down when they were positive, and infected a lot of kids unnecessarily. Also, she was unvaccinated. He was unvaccinated. I don't know. I'm sorry, I don't know. That teacher was unvaccinated, which I encourage all of our teachers to get vaccinated. And if you have any questions, please call me. This next one is from Medar-Vix, right? Excuse me if I can't pronounce that. But this basically talks about aerosol transmission in schools and the effectiveness of different interventions. The conclusion is on the first page, and it kind of does a pretty good summary of it. These measures should be combined and implemented. So natural ventilation, face masks, and HEPA filtration are effective interventions to reduce SARS-CoV-2 aerosol transmission. These measures should be combined and complemented by additional interventions, physical distancing, hygiene, testing, contact tracing, and vaccination to maximize benefit. Meaning we can't just look at one thing when we're talking about COVID mitigation in a classroom or in a building. We have to combine all of those things together to make sure we're providing adequate protection. And one of the things that this study kind of points out is that the combined approach is best, and there was a greater than 30-fold decrease in positive cases if all of those countermeasures were implemented. There was about a 14-fold decrease in positive cases with only natural ventilation. And there was another mask provided about an 8-fold decrease when they were the only thing utilized. So again, that combination of efforts is best. And we know that masks get the majority of the attention, but we can't ignore ventilation, keeping the doors open, making sure that we're keeping our kids as far apart as possible. And again, I encourage everybody to read this study because it's pretty interesting. And so this study is about post-acute COVID-19 syndrome, which is another thing why we have to consider every positive test result. And it specifically mentions a bunch of the long COVID symptoms that people are having in different systems inside the body. Their management considerations. This is a bit dense and more on the medical side, but it does talk about the multi-system inflammatory syndrome in children, which is basically 21-year-olds or less with a fever, elevated inflammatory markers, multiple organ dysfunction, current or recent SARS-CoV-2 positive test, and the exclusion of other diagnoses. So if you have a test and you have all of these other things, we can call that the MIS in children, which can lead to long-term medical problems. And the data is not all together for that, but I mean, we have about some time with it now, and lots of studies are still ongoing. Which leads me into the next one, which is talking about children with long COVID in schools in the UK. Of the 500,000 children in the UK who have tested positive for COVID-19, almost 13% still had symptoms 5 weeks after initial infection. And that's a statistically significant number. And we're basically talking about 1 out of 10 of our kids is going to continue coughing for 5 months, almost all the way through the school year. And then another 14 and a half, ages 12 to 16, had symptoms 5 weeks after that. So not quite as bad in children, but almost as equal to kids 12 to 16. This does a pretty good job of explaining all that, way better than I think I can, and I encourage everyone to take a look at that too, because there's some anecdotal evidence supported by parent statements in that as well. And I don't want to use that as a scare tactic. I just want everybody to understand this is why we consider every single case. This is why we consider all of our positive cases, and each one are looked at uniquely in and of its own to be given the best possible advice. And we can't just say things like, well, the death rate is only because we're not considering the entirety of the person, we're not considering the entirety of the community, we're not considering the entirety of the household. I understand it's easy to say, well, the death rate is X, so we don't have to worry about it, or whatever that is. It just doesn't tell the whole story. And to understand the whole story, we have to understand what is happening in each household and what could happen in each household. That's one of the main reasons we should not disassociate our children's unvaccinated status and their ability to potentially infect members of their home and members of the community. And also, we can't just ignore cases and say everything's going to be fine, because we don't necessarily know that either. I don't want to fearmonger. I don't think that's appropriate, but this is just what the science is indicating right now. I'm not making any statement based off anything else but the research I read, and again, if anybody wants it, I'll happily share with anybody who asks. And I think that's really all I got for the COVID update, unless anybody has any questions.
Anybody have any questions? All right. Hearing no questions, we can move on to our vaccine update, clinic availability, and FDA approval discussion.
Okay. Do you mind?
Oh, no, I was just expecting you to.
So I did give out one more thing that I thought was really important to share. And that was the new COVID cases. This is also from the CDC's Morbidity and Mortality Weekly Report, which I encourage everybody to check out often, because it's a lot of good information. And the new reports and new studies are usually published there first, and contains a lot of information. If anybody has any questions about that and they want to kind of dig into the weeds, please call. Me and Lindsay do a lot of trying our best to learn all this stuff if we don't know it, or if we can connect you with someone who's a bit more of an expert than we are. So this was, it looks at COVID-19 cases and hospitalizations in New York based on their vaccination status. And the real meat and potatoes, if you'll use that tired expression, is on the third page, technically next to the second page. That bottom right chart where it says all adults aged 18 years and older. You see that top dotted line right there? That is the vaccine effectiveness. And you can see that it kind of decreases from around 90 to around 80 at around we'll call it the middle of June, where it really starts to dip there. That's when COVID, the Delta variant of COVID, became most active, and that's supported by the testing data and the sequencing data that's also mentioned in this study. That dashed line, where it kind of does the scoop in the middle, that is the unvaccinated cases per 100,000 in the unvaccinated. And you can see that number starts to logarithmically change, right? It starts that exponential growth around the same time as the top line starts to dip below than the vaccinated effectiveness. That short dotted line underneath that is the average of the unvaccinated, which is super high and steep around the end of June, and the breakthroughs, which is that solid line at the bottom. And you can see that starts to uptick slightly at around all the same time. And that's when Delta kind of took over in New York and then outcompeted Alpha. So that's just a visual representation of the cases that they were seeing and the vaccine's effectiveness, right? And I tell you that to be able to turn the page and tell you that the same exact chart on the next page. This is hospitalizations, and this is where we're really learning how effective the vaccines are. This is where the money really is made. The effectiveness stayed really high against hospitalization. See how it stayed in the mid to upper 90s? That's that top line, still that dashed line at the very top. That's the effectiveness of the vaccine. It stayed in the high 90s. The cases of hospitalized unvaxxed is still that thickly dashed line, and it stayed all the way down there in the bottom. The average is still that thin dotted line, and then that straight line is the breakthrough cases. And you can see it still stays next to 0. So what does that tell us? That there's some decrease in effectiveness against cases, and we know that. We've seen that. That's what Delta is telling us. But where it's really important is that the vaccines are still very effective at preventing hospitalizations and deaths, which is the best we can possibly ask for. So, and that's another thing that kind of is lost and people can't seem to read past the headlines some. So when they talk about vaccine efficacy, right, it might be lower in preventing a case from happening, but it's still extraordinarily high in keeping you out of the hospital or out of, a worse outcome. So for vaccine clinics, if anybody has any questions, I'll move on to our availabilities. So we do have the availability to order vaccine on our own, and we still have a partnership with our friends at Bridgewater State to help us gather vaccines. We don't have kind of an abridged schedule at the schools anymore, because they were doing remote Wednesdays, if everybody recalls, last year during the school year, and that kind of helped us be able to schedule our vaccine clinics that day of the week. And that was really useful because we could utilize volunteers and staff that would normally be elsewhere in school doing things to help us. Our plan is to still offer as many COVID-19 vaccination clinics as we can. We just have to figure out the logistical challenges of doing so. They also switched platforms. They went to basically a different scheduling and tracking platform. They used PrepMod, now they're using Color. But I do want to, if I could just advertise for our friends at Massasoit Community College. I sent all of you the link for that vaccine walk-in clinic. They're doing that. Please check our Facebook page and the website to get those dates. And they're just doing a walk-in, so you can walk in during the open hours and get that done. So I don't have a lot of solid dates for our clinic's vaccine yet, because I just don't know what logistical challenges we're going to face. And I would like to hold at least 3 before the end of October, because I know a lot of people are concerned about that 81% vaccine percentages that the schools has to meet before then. And we want to make sure that we're doing all we can to get them as close to that number as required. And I also anticipate EUA for under 12 by the end of the month still. I still stand by that. My crystal ball tells me that's about that. And the FDA did approve the Pfizer vaccine for use in 16 and older. And I encourage everybody to talk to their doctor about what that means for you. And if the FDA approval was a point of contention for you not getting or getting the vaccine, now is the time to go get that Pfizer vaccine, because it has received full FDA approval. And there's a lot of discussion about that being rushed. I assure you it was not rushed. It had the most scientists working on it ever. And one of the reasons, because it shut down the entire world, so everybody was busy sequencing or looking up exactly how to figure out a vaccine for COVID-19. It had money, it had availability of researchers, it had availability of test applicants, so a lot of the studies were run concurrently. And I think a bigger question should be, why aren't we doing that with a lot of vaccines? So full FDA approval, please go get and based on the data that I showed, I think the vaccines are doing a good job of proving that they are effective against the worst parts of COVID, which is keeping people out of the hospital and keeping them upright. Any questions? Yes, ma'am.
So I do realize that you asked if we had any questions to send to you beforehand.
Sure.
So, and I didn't do my own research, it just came to me here, so if this is something to table to later, I understand.
I will do my best.
In our town, are we tracking the difference between COVID cases and COVID Delta cases?
So it's difficult for us to track that data because so we have to rely on the state's labs to sequence them.
Right.
So we do know which cases come back as Delta, and all of them are coming back as Delta now. The vast majority of them that are being sequenced are coming back as Delta because it has outcompeted the Alpha variant. So there are ways to tell which case is which, but at this point, because of the outcompete status, it's safe to assume that the vast majority of cases will be Delta.
Okay, so like in layman's terms, it would be like a practical assumption for Abington residents to assume that Delta is here in Abington.
Oh, yeah,
It's,
100%,
okay.
yeah.
That's kind of what I'm asking. I see a lot in the news about Delta outbreaks, and just in
Right.
Abington specifically, it wasn't something I was honestly, even myself, was sure about.
That it is, and it is the majority of our cases now.
Okay, thank you so much, and I do apologize because I tried to send you this beforehand.
No problem.
Just a quick question on the clinics. Boosters, will people be able to get boosters?
So the boosters right now are 8 months from the initial vaccination, for the second shot, excuse me, for the completion of the vaccination series. If I'm doing my math right, our first of those was done in February 5th. So our first vaccine booster clinic won't be available or won't be necessary until October.
Mm-hmm.
There are plans, we will be doing that, especially for, I think it's important to target the elderly population, which they were the first ones to get it, and our first responders, that they were the first ones to get it, if they want it, and then kind of move down the list from there, like we did in last year, or well, at the beginning of this year. So there are lots of plans to do the boosters, and again, it's going to be a little logistically challenging.
Yep.
We'll probably do it at the senior center again because that's where our elderly are most comfortable with, and I don't think we should change that.
Just to clarify on that, you're going to offer boosters to anybody that needs to get a booster, correct?
Yes,
Okay.
yes. I will probably target specific
Yeah.
first because that just kind of makes the most logistical sense.
But not just people that were vaccinated in Abington, anybody that
Yeah.
needs a booster will get a booster.
Yeah, I don't think we've ever turned anybody away at the little
Okay.
clinic, so yeah,
Okay.
please.
Marty,
And-
what? Go ahead.
Sorry, go ahead.
Go ahead, that's fine.
I was gonna say, and most of our clinics, I'm not gonna say, hey, where are you from? If you're here for a shot and we got it, you're getting it.
What percentage of the 12 to 18 are in Abington, the school-age children that can get vaccinated? Do you know?
I don't know off the top of my head, but you can find that information on the state's link that I sent you earlier today about
Okay.
vaccination rates. And it breaks it down from 19 to, I think it's 12.
12.
And I don't remember exactly why that was. Can I piggyback off of that?
Yep, sure.
For facts, I think it's important to state that with the new DESI requirements, I am anticipating a new reporting mechanism for those percentages. It would shock me to find out that they're not going to fix that reporting mechanism to reference just the 12 to 18, which is typical school-age children. If they didn't do that, I would be surprised. So I would anticipate new percentages and new ways to calculate that coming out soon. And I don't know if DESI is going to be the one to dictate that percentage, or they're going to tell DPH to do it, or they're going to tell us to do it. I honestly don't know. But it's easiest to find that number there, and I could click on the
I can
link that I
find
sent
it,
you
yeah,
today,
yeah.
and yeah, you can find it's pretty easy.
And if I'm not mistaken, I think I looked at that number last week. It was probably in the mid-50s, something
It's
like that.
close to
So,
that. I don't
Yeah.
want to.
Yeah, I don't want to say for
Yeah.
sure, but I know I did. Somebody
That's
did ask that
ballpark.
question, and I did look into it. So somewhere around there. That's the best answer I could give. Any other discussion on the vaccine update, or any questions for Marty? Okay, hearing none, we'll move to our last agenda item, which is mask mandate discussion on parameters for townwide and vote if applicable. Before I turn it over to the board for discussion, is there anything, Marty, you wanted to add on this?
I would. So before I would give any mask mandate recommendation for all buildings in town, and to include schools and businesses and town buildings, I think it would be important for me to have identified, or for me and Lindsay to identify, significant community spread, or without like inciting incidents. If there's like a thing that happened, a party, and some people got COVID, and we knew that number was going to decrease after 10 days, then that might not be an actual indicator of what is actually happening in town. For me to want to say, hey, ladies and gentlemen of the board, it's probably a good idea to make a mask mandate for it would have to be an uptick increasing in the test positivity in the neighborhood of 5 or higher, increase the cases that are seeming to spread in the community without any mitigation factors helping out. And with having 25 cases and a test positivity rate in 3, I think it's, I don't think I can make that recommendation right now, and I think it would be a little short-sighted to do so. And I think it might have a bit of a negative connotation, especially when we're promoting vaccination as much as we are. I'd much rather people focus their attention currently on vaccination. And thanks for letting me yammer on about that.
Of course. So I would open this up to the board. Any discussion? Yes, Melissa.
I prepared a statement tonight in response to the last couple of weeks and what we've been dealing with. As previous pandemic response state mandates have frustrated and burdened our residents, every decision we make will be scrutinized. In our path forward, I ask that we keep in mind the following CDC STARK framework. Public messages in a crisis should be simple, timely, accurate, relevant, credible, and consistent. Successful communication is built on credibility and trust. We are fortunate in Abington to have Marty Golightly as our public health director. Marty is certified in public health through the National Board of Public Health Examiners. This means he has competency in the following areas: evidence-based approaches, communication, leadership, law and ethics, biology and human disease risk, planning and evaluation, management, policy, equity, and collaboration and partnership. I'm here tonight to stress Marty's recommendations have merit behind them. Additionally, I challenge the board to self-reflect on those 10 areas of competence and consider how you can grow professionally into your role in the Board of Health. And finally, we must listen to the residents of Abington. Their participation in any public health interventions relies on a relationship of trust and credibility. Some of that is in response to the first meeting that was called to be held on remotely and on Facebook, and the miscommunication. I believe there was a copy and paste possibly that happened on the agenda to move that forward with the regulations of the past, and that created a lot of outrage from our community. We need to be very careful of that. I'd like to request that we discuss logistics about remote meetings moving forward, as that might be something that we need to do moving forward, and we have the capability from the regulations until April to do so at this point. And thank you.
Thank you, Melissa. Any other discussion? Yes, Christine.
So just discuss on the mask mandate. So based on the data that's been supplied from our health agent, Marty, who I will say I think you're doing a fantastic job.
Thank
I really appreciate the proactiveness that you send things. I appreciate the transparency, and I appreciate your willingness to explain to me like I'm 5, because I don't have your credentials, but I am in a position where I have to make a judgment call. So based on that, my main concern, honestly, was the school system starting without a protective perimeter in place. Based on the evidence I've seen, having residents congregate in close quarters without any type of protection in place is the highest risk scenario. I myself, go on the record, I do not feel comfortable with having our students not have a choice but to attend the school system in close quarters without any protection. I was not in favor of our recent meetings being canceled, because at the time I felt an obligation to our residents who had encouraged to come and vocalize. In hindsight, being 50-50, I completely understand why we canceled. That was the practical and logistic consideration, fully support it now, looking back, but at the time I was a little bit bewildered. At this time, based on the fact that my primary concern was for the congregation of unvaccinated residents, which are the children, that's been mitigated. At this time, I don't feel that there's necessary for a mask mandate for the town, but I would appreciate it, because we are in a pandemic trending upwards, that we keep this on an agenda item so that we proactively have it on our agenda if that's an option. And that's all I have to say about that.
Thank you, Christina. Does anybody else have anything to add?
I agree with Christina
okay.
to keep this on our agenda so that it's not a point of outrage whenever we discuss it.
Yes.
Well, I do think that we would be reactive if there was a situation where we did have an outbreak and that we had to change course, that we would in fact, have a meeting, because we obviously can do a meeting within 48 hours if need be. So I would just like to also, mention, I appreciate the efforts of your team, Marty, and yourself, and it's gives us great confidence, moving forward, dealing with the community. And I agree that, I think we said at the last meeting that obviously that the 12 to 18 or everyone under 12 rather could not be vaccinated, so therefore masks would be recommended, or if not mandated at that point in time. Obviously the state stepped in at that point to mandate the mask usage across the whole state, which I think was a wise choice. I think going forward, I think we just have to watch not only Abington but also neighboring communities, what's the transition and spread of COVID, and to ensure that we're able to stay on top of it. If we do have to change course, that we can do it immediately.
Any other discussion?
Aaron, you want me to keep the mask mandate discussion on parameters for townwide and vote, if applicable, just keep that wording in place for the whole time?
Yes, I do.
Okay.
I do want to just finish our discussion here. This has been one of the most confusing times for me as chair, because there have been so many back and forths over the past 2 weeks. And there are many logistical hurdles that I've been through that have made it difficult for me to make the easiest choice. So I completely understand wholeheartedly the challenges that we faced over the past weeks, and I want to use that as a learning opportunity for all of us to try and pivot as we need to. So I genuinely appreciate everyone's feedback on how we've gone through this situation. I hope that we keep this as an agenda item, I don't hope we're going to, I just decided that, but we'll keep this as an agenda item to discuss so that we can act if we need to. This is, in my opinion, one of the minimal efforts we can take the minute we start to see anything go awry. And I'd like to be able to act on that as soon as possible. So thank you to everybody for being patient. Thank you to Marty for all of your help, helping me through this, helping the whole board through all of what's been going on. And I hope that we can continue to make the positive change that we have. Well, hearing no other discussion on this item, I can entertain a motion to adjourn.
I'll make a motion to adjourn.
Second.
Any discussion? All those in favor?
Aye.
Aye. Opposed? It's unanimous. We are adjourned.